Yeah, so this is just an update. So I just went to the North Dakota Health website, and this is as of yesterday that there were about almost 60% of the facilities have one case of COVID as of the last couple of weeks, and that's split up. You can see kind of a 5-to-1 ratio here. So I guess I don't know if it's any good news or bad news, but the proportionality is much less for the residents, and this is coming post-vaccination, which I think is perhaps to be interpreted as a good sign. The fact that there are still many staff members, relatively many staff members, that are still getting COVID is still of a concern, particularly in light of the fact that we should be down on the lower side of transmissibility or transmission these days. Next slide, please. Yeah, so kind of the good news, this is North Dakota data. So it just shows that overall 90% is my understanding of long-term care residents have been vaccinated, and we're hovering close to around 60% of staff, which apparently is also the case for some of the area hospitals. But you can see the good news is that the most vulnerable, the 80-year-olds there in the blue line, have quite a few have gotten the first vaccine. So this just represents the first vaccine, and it's actually 80% of 80 and older who have gotten both doses of the vaccine. So it seems like the uptake, for the older adults, particularly in long-term care, is pretty good, and that's good. Next slide, please. So today, what we'd like to do is describe the different testing options, get feedback from folks as to what they've observed with the testing options. We're actually in a stage now where nasopharyngeal testing burnout may be an issue, and the question of whether we should be looking at things like the saliva test, antigen test, and so forth. So a lot of questions coming up still. And the other question is, how do we follow the guidance from the CDC and CMS for testing? And then also just to talk generally about the factors that may impact the interpretation of test results, which, as we know, the antigen testing is a little less sensitive than the PCR-based testing. Next slide, please. So I think really the most essential point is that, everybody says, why do I have to get tested? And part of that is that the viral testing is an important factor in infection control. And not only for COVID-19, but other infections too, such as influenza and respiratory syncytial virus, both of which are not as highly transmittable, but still are communicable diseases in the, what I call a particulate matter or a respiratory droplet. I don't know if you all saw the report that just came out of New Zealand, but they had a very interesting epidemiology report where they quarantined a group of people off of a flight that was coming into New Zealand, and they quarantined them in the hotel, and they found out that that the flight itself was only 1/3 occupancy. Nonetheless, a handful of people developed COVID, and they tracked it from the flight itself based upon genotyping. So they all had the same virus, the exact same virus. So somebody or somebodies transmitted the virus on the plane. Everybody was masked, which was interesting. And they also found that then there were 9 individuals who were, everybody was quarantined in a hotel. And what they discovered is that 3 more people developed COVID within that 14-day period, and they found that it was transmitted from basically room to room by air droplets as the testers went from hotel room to hotel room in a poorly ventilated hallway. That this virus escaped into the hallway and infected some people who were living next door in this hallway setting. So it just goes to show you the transmissibility in terms of I think the take-home message is that um, a closed door environment, in thinking about long-term care, that even a closed door environment, you can still transmit the virus from room to room just by movement of people, and not having adequate ventilation. So that's in terms of environmental design, something that we all need to reflect on in terms of redesign and ventilation opportunities in all of our facilities. Okay, a little bit of digression there. Next slide, please. Yeah, so this I highlighted a couple of things here. On the left-hand side is, we need to test when we suspect symptoms, and of course it's a no-brainer when there's a fever, cough, shortness of breath. But there's those more vague symptoms of fatigue. Quite honestly, there's some post-vaccination fatigue that's going on, and so you go like, whoa, what's up with that? And then the big one for me is now that we're entering the allergy season, is congestion or runny nose, which again should be a symptom that precipitates the COVID testing. And of course, just as a reminder, on that right-hand side column there is the issues related to older adults, that older adults tend to have not asymptomatic, but atypical presentation of all viral diseases, not just COVID. And sometimes they just, they'll refuse their plate, so there's loss of appetite, anorexia. They may complain of abdominal pain, or they may present with confusion. And I think it's also important to point out that when individuals who may be confused may also be hypoactive. And so if somebody takes to bed and is just like, just can't get them going, that could be hypoactive delirium. And that's a geriatric syndrome that goes often unrecognized in the hospital setting. And so certainly, thinking about this in the long-term care setting, I think is an important issue to stress, that delirium has two forms, hyperactive and hypoactive. And it turns out that 75% of the time, delirium is the hypoactive phase. And so again, these are the people that are just become a little bit more listless, not as engaged, who may also then have that combination of loss of appetite or refuse their meals. So delirium testing through something like the confusion assessment method or some formal way to assess delirium, I think would be an important bedside clinical assessment. But again, that would be also cause for testing. And then, as it turns out, falls are associated with COVID. That's been reported. So a fall incidence should also initiate COVID testing. But anyways, I just wanted to point out that the sort of conundrum that we're dealing with post-vaccinated individuals and these more subtler symptoms, because presumably once we get vaccinated, that the symptomatology, and there's going to be maybe even more asymptomatic COVID infections, and so we need to be even on a higher alert for subtler changes that would prompt testing. Okay, next slide, please. So this slide, is a publication from last year, and it basically shows in that light blue line how the PCR test can remain positive, and it also can be positive in asymptomatic individuals, right? So that dotted line there on the left represents asymptomatic COVID infections, and those usually they think are 3 to 4 days. I mean, they go up to a week, but that's the real dilemma, is that we get so many people who are brewing COVID infection, but they're just nothing, they're not reacting to it in a 3 to 4 day period, but they can still spread it through oral droplets or sneezing and hand contact. So anyways, I'm sorry, I wasn't quite done with that slide. Thank you. Um, and then I just want to point out the antibody detection. So those are the purple and the green dots there. About 1 week to 10 days after you get the infection, you start to develop antibodies. So that's why we've used the window of 2 weeks after your second mRNA vaccination for peak antibody activity. That process, quite honestly, might be a little slower in older adults. So I'm not sure the 2 week period is the correct time. It may be more like 3 weeks, before they're fully immunized. But that may be splitting hairs, really, because basically, if you're vaccinated, you're vaccinated. Okay, next slide, please. And just to separate our understanding, that the PCR test versus the antigen test versus that third column there of serologic tests, right? So the nasopharyngeal swabs are basically to detect SARS-CoV-2 or the COVID virus. And we'll talk a little bit about the differences in their sensitivity to do so. But then also to point out that in terms of serology, that you can get a blood test to measure whether you've had COVID or not. And again, these occur about 2 weeks afterwards. They're not diagnostic for a current infection. They're representative of somebody who may have been infected. And I just haven't seen much information as to people who have had strong reactions to the vaccine as to whether they've had previous COVID antibodies. So I'm looking for that data, because my clinical suspicion is that people who have had strong reactions to the COVID vaccine are people who actually have had COVID and didn't know it. But that again, that's just speculation on my part. Okay, next slide, please. So again, separating the distinction rather between the nasopharyngeal swab and blood tests. The viral diagnostic tests are the ones that we use for COVID infection. There's not a blood test, although theoretically you could take blood and test it with those PCR tests, but that's just not the way to go. And then the other point is that in terms of even if you know that somebody had a positive antigen test, by a blood test, or know that they've had COVID before, the sequence of testing with the antigen and then PCR testing afterwards is still should be in place, because there is the possibility of reinfection. It happens most commonly. Reinfections most commonly occur in healthcare workers and in elderly. So again, just because you had COVID before doesn't mean you can't get it again. Next slide, please. Yeah, so this basically separates the PCR test from the antigen test. So the PCR test is highly sensitive, it means it can detect the disease. Whereas the antigen test is a little less sensitive and is actually more specific. So what that means is that if you've got the disease, the antigen test is going to pretty much pick it up. But if you are in the pre-symptomatic stage, then the antigen test is not quite as good. So that's sort of the knock on the Bionex and the other antigen tests, including the new saliva test. Next slide, please. So this just reemphasizes that the high sensitivity that we get with the PCR test allows us to detect the infection pretty rigorously. But the problem is that as we go to lower sensitivity, it leads to a higher false negative result. So you kind of miss the infections. And that's the problem with the antigen test, is that it is less sensitive. And so we tend to get higher false negative results as a consequence of that. Next slide, please. So in terms of testing strategies, we use these diagnostic tests, the antigen and the PCR test to diagnose a current infection. As we had in our poll, we want to identify outbreaks, as well as individuals with signs or symptoms that are consistent with a viral infection, and then also asymptomatic individuals with suspected exposure to COVID. Next slide, please. So in terms of our testing strategies for screening, we want to identify asymptomatic infected individuals. And that's quite honestly part of the another ongoing issue that we have is that as we lower our testing rates to weekly or monthly, we're going to miss a lot of asymptomatic people, which really is going to be the sneaking under the wire infectivity that we're so concerned about. Next slide, please. So the current recommendations for nursing home testing is that all symptomatic residents and staff should be tested. We ideally should have a 24-hour turnaround time on these tests, which I think early on in the pandemic was a little bit of an issue. We weren't hearing for like 72 hours, and I think the turnaround time has gotten a little bit better. So that's good to know. Next slide, please. So the recommendations for if there's an outbreak, so this should be testing triggered by a new COVID infection by any staff or resident. So of these 24 nursing homes that have a newly expressed COVID infection in either staff or residents, they have to go through this testing strategy. And so, and that contrasts with the non-outbreak testing, where you test all residents and staff once as part of a reopening, and you're supposed to have 14 days after that before you, do any type of reopening maneuvers. And then serial staff screening, so testing asymptomatic staff at a frequency determined by the your local county positivity rate. And so that's related to either a monthly rate under 2% versus weekly. And then of course, twice weekly, I believe is if you have a positivity rate above 10% in the county. Next slide, please. In terms of outbreak testing, in response to a new case in the facility, you want to expand the testing for all residents and staff. So it should be facility-wide. That sometimes may be curtailed to a unit-based testing strategy if there's a paucity or not enough tests to perform. And then you want to perform repeat testing of all individuals who are negative, so both staff and residents. And the idea is to optimally do this every 3 days during the first 14 days of an index case, and then thereafter test weekly. And there should be continued serial testing until no new positive cases were identified from the last outbreak or index case. And then again, as I commented, if testing capacity is limited, then you try to prioritize the testing for the residents with known exposures or residents and staff from the particular unit that was affected, as well as importantly, residents such as dialysis patients who leave and return to the facility on a regular basis. Next slide, please. So this slide, a little hard to read, but basically what the take-home message from the slide, it's almost 90 nursing homes here. The bottom line is that the longer it takes to get the test results, the more likely you're going to have an infection spread. So that's why you see that line going upwards, where the number of days from the first positive test before action is taken. So basically, rapid testing is really vital, to curtailing the COVID infections in long-term care. Next slide, please. So some of the considerations for testing planning is, in terms of managing residents and staff who have clinically recovered from COVID. So in that 3 to month period post-infection, there's no need for quarantining or testing after their 14-day period or recovery period. And then after 3 months post-infection, it would be well to retest if symptoms do occur, and then consider that as a new or recurrent infection. Fortunately, those numbers have not been large, but there is sufficient data from the acute care hospital settings that indicate repetitive infections in otherwise healthy healthcare staff. So you can only imagine the possibility for older adults getting reinfected down the road. And we don't know, quite honestly, as to how older adults who have been vaccinated as to what their susceptibility rate is. There's really no information on older adults. All we know is that they just there's a 0% probability of them going to the hospital, but that doesn't say anything about their if they are infected as a vaccinated individual as to the severity of the illness in terms of respiratory or duration. Okay, next slide, please. So if there's no outbreak benefit of regular testing that we know about, I mean, this is an issue. There could be over-testing could result in false positive results and then prompt some additional testing. So that's always the balance. That's why, nobody recommended testing every day, right? I mean, you would say, why don't we just test every day and we'll find it? And the reason is that it could create those false positive results. And I think the emphasis from the CDC is that it would be well to test asymptomatic residents who leave the facility. Again, anybody that's exposed to the community, if they go home to visit, family members, or they go out to a dialysis center, or they go weekly for some injections, like, whatever, they might get in the clinics, that those people should be tested on a regular basis. Next slide, please. So this is the algorithm for testing both symptomatic and asymptomatic. I think what we can do is get a copy of this and send this out to you so you can post this as, for your infection control person, your medical director, so that you can have this as part of your plan for testing. So, if a surveyor says, what's your plan for testing, you can pull out this algorithm, and this will do the trick. Next slide, please. Yeah, so this is just more or less quality control and rigor of testing. So you can see here the talking points is that the quality of the specimen collection may be at issue. We sometimes call them air swabs. That you get a test and you just don't get adequate tissue specimens. And then also the degradation of the testing. So if you get a test and get a swab and you run it 2 days, 3 days later, there could be significant degradation of the sample, then giving it a false negative. Okay, next slide. So some of the factors that we want to consider for interpretation of test results, certainly the testing platform should be as pristine as possible. If it's point of care testing, personnel should be specified and trained. There should be a specific point of care testing space designated where it's cleaned and disinfected on a regular basis, and that the quality controls should be used according to instructions. Next slide, please. So if you get a test with the Bionex or whatever antigen test is being used, that the follow-up is to get a PCR test. The staff should be excluded from work, and the resident should be placed in quarantine or transmission-based precautions. If you're doing what we call in situ, or leave them in the room, but they should not have a roommate. Additional testing of asymptomatic residents and close contacts can be delayed until the PCR test, with the exception that if they have symptoms, then you go ahead and test again with the antigen. And then the important point is that you only move residents with confirmed infection to a dedicated COVID unit after that PCR test. So the antigen test is not the basis for moving them. It is for isolating them, but not for moving them to the COVID unit. And then finally, the confirmatory PCR testing after a positive antigen test is not recommended when the person being tested is both asymptomatic or had known exposure to COVID. Okay, next slide, please. The limitations to our testing strategies is that a single negative test does not necessarily rule out COVID, and that's why serial testing is important. And there's a 14-day window, and we'll talk a little bit about this in terms of quarantine strategies, because most of the manifestations of COVID occur within 5 days of exposure, but can linger, through those 2 weeks. And then also, one of the questions that came up and that highlighted in yellow is that you can't use a test-based strategy for eliminating, or not eliminating, but rather not quarantining a newly admitted individual to the facility. Okay, next slide, please. So again, the clinical circumstances are important for test interpretation. So if you do have a negative test, but still have symptoms that are consistent with an infection, you have to use your clinical judgment about how to handle that, and then also to do retesting if your clinical suspicion is high. So the other part is that if you find it, let's say you've got an outbreak, and that second point there is that if you have a positive test in an asymptomatic person, that needs to be interrogated a little bit more closely, because that may be a false positive test. Those circumstances don't come up that frequently, quite honestly, but that is the strategy that you need to think about. Next slide, please. Yeah, I think this all is common sense, that the testing is not going to keep COVID out, but it is part of a overall comprehensive strategy that includes infection control, disinfection, wearing of masks, and all the elements that we talk about for protecting residents and staff. And like I say, it's just real interesting right now that the data is showing that the vast majority of COVID in nursing homes is amongst staff and not so much amongst residents. So hopefully that, like I say, is an indicator of where we need to put our efforts, for educating staff about COVID spread. Okay, next slide, please. Yeah, so I just wanted to point this out. I don't think we have Faye here. Maybe Vanessa can comment on this if she joined us from the Long-Term Care Association. But bottom line is that 14 days is the quarantine duration for a positive test and post COVID infection. But there's a test and a no test option. So you can get it down to 10 days without testing if you monitor daily and there's no additional symptoms. And so in that instance that you are going to get 1 out of 100 cases that are still infected, within that 10 to 14 day period. So that's a reasonable risk, that needs to be considered. And then the second option is quarantining for 7 days with a test at day 5 or 6. And that if you get a negative test with no symptoms, that's another strategy for reducing quarantining, particularly for for staff, because anyways, that's because of staff shortages. But the point being there is that you now increase the risk of missing a lingering infection by 5%. So that's a little higher odds, and needs to be taken in the context of staffing levels and the importance of the individual to get back to work sooner rather than later. Next slide, please. So I looked up the data from CMS. So they have not updated anything about the reopening process. So we're still pretty much in limbo about that. But just to emphasize that any type of gestures or decisions to reopen requires a 14-day post-COVID screening strategy that's facility-wide. So I think that's an important point to make. Next slide, I think that may be, these are just resources. So this slide deck is available to all of you, and you can see the different resources that you have there. So you can copy and paste those if you wish. Next slide, please. And again, some additional resources that come from the CDC primarily. So these, provide infection control guidance, the SARS testing guidance, some assessment tools for detecting COVID, and additional training resources. Next slide. That's it. We can open up to any questions, and if we have any questions, I'm happy to answer them next, and then we'll move into our next section on quality improvement.
Hey, Dr. Jurevich, this is Vanessa. I just wanted to weigh in. This CMS did come out with some revised visitation guidance last week, Wednesday. And, it all depends. They just wanted to allow nursing home residents that psychosocial interaction. And our VP3 team is still working through some of the guidance, clarifying before they put out their recommendations that, the facilities have been following for the state of North Dakota. Unfortunately, I can't talk to it today. I haven't gotten that guidance yet. So facilities are encouraged, if you have any questions regarding the visitation, that you call the VP3 team and talk through your situation. And also, if you, go ahead and open up visitation the way you see fit, following the guidance by CMS. I guess that's what I can say for right now until we hear more from the VP3 team. Thank you.
Yeah, that's a good point. And I think it also, again, using good sensibilities here, because we're seeing a little bit of an uptick, right, in the positivity rate. We've gone from 2.9% to 4%, and North Dakota in particular is one of the 10 states that's showing a little nib upwards towards positivity rates, and so we need to be really quite cautious, particularly with the relaxation of masking requirements in the community. So yeah, I think it's we don't want to get ahead of the skis, as they say. Not that there's a lot of skiing in North Dakota, but so all righty, good. Thank you for that comment, Vanessa. And like I say, as soon as it's hot off the press, we'll distribute this information as best we know it. So Michelle and Kelly, do you want to move into your quality improvement presentation here?
Yes, absolutely. And good afternoon, everyone. We'll be sharing a peer performance improvement plan at the end of this. So I am going to be watching the time so I don't we don't miss it this week. So just to follow up from last week, we talked about focusing on the process and verifying that your process is reliable by interviewing 5 staff and asking those 5 questions: the who, when, where, how, and what. And in the chat, if you could just chime if you were able to determine or identify a process that you wanted to investigate and what you learned whenever you were having those conversations with your staff. So I'm going to go ahead and move to the next slide, but as we're going through, just chat in, and then if we have some comments, we'll stop and address those. So as mentioned last week, we discussed verifying those systems if they were reliable. And, you know, whenever you determine, when you're looking at that system, we talked last week about it being an infrequent failure or a common failure. Well, this flow chart right here helps identify whether you need to create a PIP or not create a PIP based on your observations and those interviews with the staff. I'm not going to go through box by box here, but once you identify the opportunity for improvement, and you'll hear later in the series where I start focusing on that these are opportunities, then you determine if it's a high degree of belief, if it's low risk, if it's low cost, if it's high staff buy-in. And once you go through those questions, you can determine if you need to start the performance improvement project or if you just need to implement a change and then monitor the issue moving forward. And go ahead and go to the next slide. This is just a quick overview of improvement in 5 steps. First, we need to figure out what the opportunity for improvement is and what the nature of it is. By that, you're using some sort of root cause analysis tool to determine what it is. Next, you're going to set a goal that you want to achieve, decide what you want to try as far as interventions go. And whenever you're looking at what interventions you want to do, go back to that those 5 questions again with the 5 staff. They will really help determine those interventions you want to use. Start by testing or trying it on a small scale. You want to do 1 unit, 1 group of residents, or 1 group of staff. Make sure it's small so you don't overwhelm the resources you have. And when I use the term resources, I'm talking about your staff who are actually working this plan. And then last but definitely not least is you have to measure your impact. And in order to see if a process or system that you've put in place is successful, you do have to use some kind of monitoring measurements. Go to the next slide. So when we talk about deciding if this is a common or an infrequent situation, you need to make sure that you're really drilling in with the staff and asking these to determine the level of severity, I guess you can say, of these issues. And really, while you're rounding, you know, we talked about rounding last week and how you can use checklists and such. Throw some of these questions into your checklist for leadership to use whenever they're rounding with staff. What are the staff and residents feeling, whatever your opportunity for improvement is? What are they feeling about it? How are their current efforts making a difference? What could be done better? You know, I've said before that the staff are the front line. They provide the most valuable input whenever you're doing your day-to-day concerns that may come up. What is a reasonable goal for your facility? Once again, keep in mind that you don't want to overwhelm your resources. So what's a reasonable goal? Make sure it's attainable. Later in the series, we'll talk about SMART goals and how you can set those to be attainable or achievable goals. And then what can you try? Ask the staff to provide ideas of what they can try. What you'll find more times than not is that your staff have worked at multiple facilities most likely, or they work at multiple at this point, and they may have had a similar or the same issue or opportunity for improvement come up, and they may be able to provide some good ideas that they've seen work. It doesn't mean it's going to absolutely work in your facility, but it's worth testing and trying that option. Go to the next slide. Next, pick something to test. We talked about this earlier. Whenever you get your intervention that you're going to put in place, test it, make sure it's small, and then measure the impact. So here's a couple of examples of how you can measure. Say you had an employee morale program you put in place, and you're really trying to improve attendance, and attendance was an issue because employees were just unhappy at work. It's what you determined during your root cause. Then maybe you can monitor that through the absentee rates or a marble measure. I know Jean, I believe, talked in one of our previous cohorts about doing marbles, setting them out for staff to drop in if it's a good day, it's a bad day, how they're feeling. And then you can determine if there is a need to address employee morale based on that marble measure. And then finally, we'll just wrap up quickly with a leave in action. Think about conversations, discoveries, observations over the past few weeks and months. You know, the past year has been quite challenging with the pandemic, and I'm sure that there's things that have come up that you've identified that you can work through. So see if it's something that you need to create a PIP for, or if it's a just do it approach, and just make that change and then monitor to ensure there aren't any further issues. And then connect with your staff members and ask those questions when you are developing that PIP to get something that the other reason you want to include staff is whenever the staff are participating in building that PIP, they're going to have a lot more buy-in and wanting to make it successful. So if they know that their idea was used during that PIP creation, they're going to try harder to prove its success. And the same being if it's even another staff member, they'll say, oh, this was built by one of my peers and they're here on the front lines. They understand what's going on. So I'm going to do this because they are here on the front line. And I'm going to look in the chat real quick if we have anything. I don't see anything, any comments from a follow-up from last week, but I want to turn it over now to Michelle to introduce our peer that is with Trinity Homes that is going to present the.
This is a PIP form that was taken off of our Great Plains Quinn site. You can use any kind of PIP form that you want that works best for you. This is just one that we have that includes all the information that is needed for a PIP. What you can see, she's got the start date here and when they want to be done, and the fact that they're going to review it monthly, who's on the teams and who's the leaders, and then this area for improvement. Falls reduction following our COVID-19 outbreak from October to December. We were not able to admit residents and experienced the loss of some of our residents. Despite reduced census, the number of falls has not dropped. And so you can see the numbers that they've got there. And she said, yes.
Hey, this is Monica.
Oh.
I don't think Jennifer could get on, but I'm here if you needed anything for us in Trinity.
Awesome. Are you able to see the screens? Is there?
Yep, sure can.
Okay, so if you want to just go ahead, and I was just getting to the SMART goal. If you want to just walk through what you guys did, that would be great.
So we wanted to make sure that it would be specific to the goal that we wanted for the area of improvement with being more specific. And then we, of course, make it measurable. So we wanted to find a number that was going to be achievable, that we wanted to get lower, but we wanted to be something that's achievable because we don't want to lose that motivation in our staff and stuff. So we want to make sure that it's something that it's a goal that they can reach. And then once we reach that goal, then we can set a new goal for something else. So our goal was to have no more than 60 falls per month by June 1st. And then we set specific goals for each unit to achieve that goal. So no more than 10 falls a month for the East units, for 2 and 3 East, and then 8 for 2 West, 5 for 3 South, 20 for 4 West and Central. That's our dementia unit. So we tend to have a lot more there. So we wanted to give them something that we felt would be achievable for them. And then 5 for 4 East. So we did set our goal at June 1st. So, through the root cause of the problem and why is it happening, our residents they had that life-changing experience. It really was with COVID. It's affected both our staff and our residents. We did have to stop the visitation, and it's so tough on these residents not being able to see their families on a daily basis like some of them did. We would have to move their rooms around. If they became positive, we'd have to move them to a positive unit. And then once they cleared, then we can move them back to their normal unit. And they got different roommates, and they just were all over the place. So they've had so many different changes going between communal dining and having to be in their rooms to eat and activities and all of that. So we wanted to make sure that we could do something that would affect that actual goal that we had in mind. So we didn't really have any barriers. I guess we'll go to
Next slide.
the next page. Yeah,
There
there
you
we go. Okay. So what we did was we developed a falls huddle tool. We know they used one over at the hospital. So what we did was we took that tool from the hospital and we actually tweaked it so it would be good for a long-term care. And what we do is anytime that there is a fall, they fill out this falls huddle tool, and then it goes to the nurse manager, and then we talk about it every single week at our falls meetings. And we talk about like what interventions were in place, what interventions can we put in place, all of that. We also have falls on our Gemba boards that we go around and we do, and we review those every day. And we also put up a QA board in our employee break room cafeteria so that everybody can look at what we're working on, the actual data coming right away. So we update it every single month so they can see exactly where we're at and if we're meeting our goal. We also have it going into our meetings, our CNA meetings, nursing meetings, all of that. So they know what we're working on and how we're doing with all of it. We put QA into our newsletters. We do have a quarterly newsletter that comes out for the homes. It's specific for the homes that we put information on our PIP and everything that's going on that, and doing individual education on each of the units. We also had our CNA competencies. They started this past Tuesday, and they have a station that is focused primarily just on falls and prevention of falls. So we go over the different types of wheelchairs, the different interventions, the other interventions that we could put into place, thinking outside the box, what can we do to help these residents and prevent these falls from even happening, how to be proactive in their thinking. So we had our plan and our do, study, and act. And we did get the board hung in the cafeteria. That was completed. And we put all of our falls data on our previous boards, and that has been updated. And then our monthly number of falls, you can see we have our benchmarks that we're going to do. Our baseline was at 70 at the end of January, and by the end of February, we were down to 40 already. So we're hoping that on March 31st, we can lower it even more. So we've actually reached that first primary goal, and we're kind of looking to do even better.
That is so great. So just a few questions I have for you and thoughts. First of all, your SMART goal is exactly what we want to see, that you did all those elements. You put specific numbers there, you put a timeline on there, and you were looking for it being achievable. That sometimes is the hard part of that SMART methodology. So you were really looking at what would be best for each unit. So awesome. I'm just wondering if this is really appears to be a big broad overview of a lot of different elements that you've got going on. Are you measuring and showing the data for each unit, like in that area?
Yes, yep, we do. We have, for each individual unit, they can see exactly where they stand with their goal, their individual goals. And then that is all put together down in the employee cafeterias where they can see each individual unit and they can see the facility as a whole.
That's so awesome. Does anybody have any questions for Monica and Jennifer on their PIP process, or feel free to?
I just want to say Kudos to you guys. It's a really great plan, and I appreciate that you bring up that you're looking at something that isn't necessarily COVID specific. I think there's been such a hyper focus on COVID. Sometimes the other areas of quality of care may have slipped through the cracks, unfortunately, as a side effect of COVID. So kudos to you guys for identifying that and putting something in place. And I love the board and the cafeteria. Great way to communicate to the staff.
Awesome, thank you.
And it looks like Jim asked, is this template available? And yes, I can put a link for that into the chat feature. If anybody else has any other questions, that would feel free to speak up.
Yeah, so Dr. Jurevich here, wondering, have there been any other interventions that you've adopted for fall prevention that were still in place? So for example, are all residents on daily vitamin D as a fall prevention intervention?
Well, when everyone comes in, they automatically are put on falls protocols. We do have where we do our scheduled fall risk scales, and we do have the star placement that we use because we didn't want to do anything that could risk dignity or respect or anything to our residents. We didn't want to call them out. So what we adopted was a little, I don't even know how big they are, maybe half an inch star. And that is put onto their door tag next to their name. And so everybody across the board gets a star. It just depends on what color you get. It depends on what your fall risk might be. So that we can, anybody walking into that room, even if you don't know that resident, you can look at the door, you can see, oh, that's a yellow star. I know they're a falls risk, so I have to make sure interventions are in place.
Yeah, that's good for identifying risk. So that's important. So that could even be a PIP in itself in terms of once you've identified risks, whether additional interventions help reduce falls. And it may mature, this kind of project could mature into a little bit even more sophisticated approach where you separate the frequent fallers from the one-timers, and seeing if you can reduce the frequent fallers through different interventions too. So you can do subset PIPs and targeted analysis. But I think the important thing too is also to consider, you used a local or hospital-based tool that I assume was proven to be effective in the hospital. That's really fantastic. And the question is whether the hospital developed these huddle tools from the medical literature or research that demonstrated, demonstrated its efficacy. So that's what also can be added into the PIP process. So that's why I asked about, for instance, vitamin D. So there's research that shows that a daily dose of 1,000 units of vitamin D reduces falls in the long-term care setting. And so that might be something that would be tested to see if it actually works in your facility. And if yes, then you adopt it. If no, then maybe not such a good idea. So yeah, that's wonderful. This is great.
Yeah, Jennifer just chatted to me that no, they haven't done anything regarding the vitamins.
Yeah. So I mean, these are all incremental. There's some recent research from my group even that shows that high variation in blood pressure tends to predict the frequent fallers. So there's not even hot off the press yet opportunities for intersecting with long-term care and what I call academia. The people who are doing the research.